So good morning, and thank you very much. Really great, and thank you for the very kind introduction, Jenny. And a huge thank you to Jenny and HealthTree. This is really such a wonderful event and our first one here in the area. I am hugely honored and proud to be part of this. Thank you all for coming out today on a Saturday. I am wearing a mask because my son has COVID. I feel fine. I've tested negative, but in case you're wondering, that's why I have the mask on. So all good, probably being overly precautious, but can never be too cautious these days. And so I have about 20 minutes to talk about kind of choices in myeloma. And a lot of this circles around therapy. I'm looking at my clock. And the goal of this is not to go into an exhaustive data dive into myeloma 2023, but as much as just to sort of sketch out some general themes that we think about when we as your physicians are thinking about treatment decisions in myeloma. When you talk to us in clinic, I'm sure you've gotten a feel for the fact that this is increasingly complex. Every year it gets more complex in a good way. It means that we have more options, but there's just a lot for us to think about. And so we thought that it would be helpful to discuss that a little bit today. And so we'll really break this down into three big picture categories. One is sort of generally how we think about treatment choices and sort of what the general considerations are. We'll talk about genetics. I'm sure especially those of you in the room who have been doing this for a while have heard quite a bit about myeloma genetics. And then we'll talk about, Jenny very appropriately highlighted clinical trials is really the only way that we get better at this whole thing. And so we'll talk a little bit about how clinical trials should factor into treatment decisions. So in terms of sort of general themes in treatment decisions, a lot of it has to do with what the patient wants. So what you want when you're talking to us in clinic. And what I mean by that is that in medicine, we often talk about goals of care. So goals of care are what we as your physician think about sort of what the aims of therapy are. And when we think about treating a cancer like multiple myeloma, it seems pretty obvious. The goal is, of course, to live for as long as possible. I want to live for as long as possible, and I want to feel good. I want my quality of life to be good. So that's all pretty straightforward. Seems like it should be pretty easy. But when we dig down into that a little bit more deeply, you see that it's actually a whole lot more complex. When we think about individual elements of these goals of care, a lot of different things come up. So it's not always about how long we want to live with this, quality of life. Rather, we think about things like depth of response and duration of remission. Some people really fixate on things like minimal residual disease, or MRD, for those who have heard of that term. Some people really want their myeloma to be MRD negative. A good treatment goal for some people, but not the end-all be-all necessarily. For some people, living for as long as possible is not the ultimate goal. The ultimate goal is to stay independent and to maintain functional status. And sometimes this is a big issue for older people with myeloma who come into it with other medical problems, functional impairments already from other medical things that happened before, where their goal is to just not let this myeloma or therapy make me worse than I am already. I want to continue living at home. I want to continue to be able to do the activities that I like doing. Symptom burden. So of course we want to treat to control symptom burden for myeloma. So that's almost always a goal of this, but on the other side of the coin, we also want to minimize the side effect burden from therapy. So we're always kind of doing this seesaw where we want to treat intensively to control myeloma-related symptoms, but on the other hand, we also don't want to cause severe therapy-related side effects. Number of medications. So those of you in the room who have been doing this for a while, I'm sure you've been through thousands of prescriptions at this point, and a lot of people say that I don't want to take that many pills. I don't want to come in for so many infusions. I want to do this once a week or once a month, not twice a week. That can be a consideration. Clinic time and burden on caregivers, the same things, the same themes. Some people say I want to, I like golfing, I like traveling, I have a graduation to go to next month. I don't want to be coming in once a week, twice a week. I want to come in once a month, once every 3 months. Cost, financial toxicity. So financial toxicity is a increasingly researched theme in cancer. We know that these medications are incredibly expensive, and for some people, minimizing cost and financial toxicity can be a goal of therapy. And the idea of paying it forward. So we're going to talk a little bit about clinical trials, but some people are very into the idea of, I want to participate in studies now so I can help future people who have this condition. So goals of care can be quite complicated. And so when we as your physicians look at these issues, and we're thinking about different treatment options, one thing that's evident is that, again, there's an increasingly large menu of different options that we have that are available for treating this. And this just highlights medications that have been approved over the last few decades. And you see that a lot of these have really come about in just the last couple of years. So again, the menu gets increasingly large, and we've lost a couple over the years. Panobinostat and then belantamab also have now been withdrawn from the market, but in general, the menu of options is getting bigger and bigger every year. And just to highlight how complex this is, don't worry about the details of this slide, but I just put this up to just illustrate how many options we have for treating myeloma these days in terms of different medications. So this is from something called NCCN. So NCCN is National Comprehensive Cancer Network. Details don't matter other than to say that these are widely available expert opinions on basically how to treat different types of cancer, including multiple myeloma. So a lot of times we look at this when we're initially getting into myeloma or cancer, fellows, kind of early faculty. These are good references to sort of get an idea for how we should do this. And this is one for lymphoma. So for lymphoma, a related but different type of cancer, so related to myeloma but different, the different cancer of the immune system. And I just put this up to point out that for high-grade B-cell lymphoma, there's basically 3 or 4 different choices for newly diagnosed lymphoma. So a pretty limited menu of different options. But then if we look at myeloma, so this is the menu of options for primary therapy, so first-line therapy for people who are possibly going on to stem cell transplants. So you can see there's probably 15, 20 different options here, which are perfectly acceptable. Then we get into relapse myeloma. This is slide 1, probably 15 to 20 options. This is slide 2, another 15 to 20. Slide 3, another 10 or so. So this just, it's probably 40 or 50 different combinations of medications that we can use, combine them in different ways, and just to say that there's a lot of different ways that we can do this. And so when we think about treatment options in myeloma, we as your physicians, we really have to think carefully about this. And so when we think about goals of care, a lot of times we have to make choices. If we want to come into clinic less often, we may need to give that up for a slightly less deep level of response for the myeloma. If we want to minimize transfusions or side effects, we may need to treat a little bit less intensively. So just to say that there's this trade-off that we need to be really careful about, and you help us with this by letting us know when we bring this up, kind of what your priorities are. In terms of specific medical considerations, so as mentioned, lots of excellent treatment options. Unfortunately, there are not a lot of head-to-head studies to really tell us which of those options is the best. So there's a lot of good ones, not totally clear which one's the best. We, again, are constantly thinking about balancing myeloma control with side effects. In certain situations, some medications are probably better than others. And one thing that I really want to highlight is that we really, especially now, myeloma 2023, we really need to think about long-term strategy. So it's not just, what are we going to use to treat myeloma today? These days, with so many different options available, some options better for certain situations, we as your myeloma physicians need to be thinking not only about what do we do today, but what do we do a year from now, 2 years from now, 5 years from now if myeloma comes back? What's the next line of therapy? What's the line of therapy after that? So ideally, your physician is really thinking about things, and I'd put a comment out there to say that this is a good reason to think about seeing myeloma experts, because we do this intuitively, whereas somebody who does myeloma less frequently may not necessarily think about these things. So genetics, what patients need to know and understand. This is a topic that can comprise a day-long symposium in and of itself, so we're not going to get into this in the gory details. But some things that I just want to highlight. So first of all, people often hear about their genetics and they think, okay, I got this from my parents and I'm going to pass it on to my children. It's not that kind of genetics. So the genetics in myeloma, we're almost always just talking about genetic changes in the myeloma cells themselves. These are not genes that you picked up from your parents and that you'll pass on to your kids. These genetic abnormalities don't exist in other cells of the body. They're genetic changes that are only in the myeloma cells. Most genetic information in myeloma is prognostic. Right now, not a lot of it is actionable. And what I mean by that is that prognosis is just generally the idea in medicine that we can guess kind of how things are likely to behave or how something is likely to go. Genetics give us an idea about that, but ideally genetics would also tell us, okay, we see this abnormality, we should use this medication, this combination, transplant, no transplant, whatever else. We unfortunately don't have that in most cases in myeloma, with the exception of venetoclax, which we'll talk about now. So don't worry about the gory details on this slide, but this just highlights the fact that venetoclax is probably the one option that we have in myeloma or the one genetic marker in myeloma that does point toward a specific therapy which is useful for it. So venetoclax is a medication that's not FDA approved for treating myeloma. It's FDA approved for treating chronic lymphocytic leukemia, other conditions like that that are related to myeloma but different. And so this is from a study called Bellini, which was a study that made quite a number of headlines in myeloma. It was a study that looked at people with relapsed and refractory myeloma, so myeloma that had come back after prior therapy. And it was a group of patients that were randomized to receive either bortezomib dexamethasone, so bortezomib is Velcade, so Velcade dexamethasone, or they got venetoclax plus the Velcade dexamethasone. So basically Velcade with or without the venetoclax medication. And so when we look at this, again, don't worry about the details. I'll kind of go through it, but if we look at the top of this, progression-free survival, let me see if I can figure out. So progression-free survival is basically time from initiation of therapy until myeloma comes back or death from any cause. And so if we look at median progression-free survival, so this is average, for people that got the venetoclax medication, 23.4 months, for people that just got the bortezomib dexamethasone, 11.4 months. So it looks like somewhat of an improvement. Not a huge difference, but somewhat of an improvement in everybody in this study who had myeloma, regardless of the presence of this thing called T1114, which is a specific genetic change that we see in some people with myeloma. If we look at progression-free survival, so again, time from initiation of therapy until relapse of the myeloma or death, specifically in people that had this T1114 abnormality, median progression-free survival in people that got venetoclax was 34.3 months versus 9.9 months in people that got the bortezomib dexamethasone. So that's a much more significant improvement, arguing that venetoclax, or that T1114, is a good marker of good response to the venetoclax medication. Now, on the other side of the coin, if we look at people that did not have that T1114 marker, and we look at, again, progression-free survival, 15.3 months for people that got venetoclax versus 12.2 months for people that did not get it. So all of a sudden we see maybe a little bit of an improvement, probably not really. But then what really made the news on this study was if we look at overall survival. So overall survival is basically time from initiation of therapy until death from any cause, myeloma, or anything else. And so if we look at the people that did not have this T1114 marker, median overall survival was 46.4 months of people that did not have it versus not reached for people that, 46.4 months for people that got the venetoclax versus not reached for people that did not get venetoclax. So 46.4 if they got venetoclax, not reached if they did not get venetoclax. So basically, overall survival was worse if people did not have that T1114 marker and they got the venetoclax medication. So this study really showed or suggested that venetoclax is beneficial in people with myeloma with that T1114 marker, but it actually can make things worse for people that do not have that T1114 marker. So just to say that this really made news in myeloma to say that T1114 is probably an important marker and that venetoclax should probably not be used in everybody, but for people that have that T1114 marker, the venetoclax medication could be helpful. And so now, but more broadly in myeloma, the theme of genetics comes up quite a bit, and most often we think of this as prognostic. So it gives us a general sense of kind of how myeloma is likely to behave over time, but beyond that, it's tough to know what to do with it. Meaning, again, genetics don't always tell us kind of how best to treat the myeloma. And this is just a slide. Don't worry about the details. It's just a slide to show that this is a study published by the French group in 2019. So this is really ancient history in myeloma world. Most of these patients would have been diagnosed over a decade ago. So this really is a long time ago. The exact numbers aren't necessarily important. But it does highlight this to show that this was a study done by the French group where they basically risk stratified people by the presence of certain genetic abnormalities. And what they found was that when people had combinations of these different markers, survival was quite different. So people that had a number of these different markers, survival was poorer. People that had one or two of them, not quite as bad. And then for people that did not have any of them, so considered to be low-risk myeloma genetically, people actually did quite well. Again, the point of this is not to say this is prognosis in 2023. It's very different these days. This just highlights the fact that genetics can be used to predict outcome in myeloma, and this is most often how we do it. But again, the issue becomes, okay, if we know that perhaps somebody has high-risk genetics with their myeloma, what do we do about that? What do we do to improve the outcome? And that's really where we're missing data these days. And so things to keep in mind about genetics are that prognosis is not concrete. And what I mean by that is that having high-risk genetics does not always mean that myeloma will go badly. Sometimes with people with high-risk genetics can do perfectly fine over years. And similarly, standard risk genetics, meaning not high-risk genetics, does not always mean that things will go well, and sometimes we're unfortunately surprised by myeloma that looks like the kind that's likely to behave itself over years, and then it relapses sooner than we like. So prognosis, it gives us a general sense of how things are likely to go, but this is hardly concrete. And again, really where a lot of the research is going on now is what to do with this information about genetics. We can use genetics to give us a general sense of how things are likely to go with a person's myeloma, but the question again that follows is, okay, what do we do with that information to improve outcomes in general? And so lastly, clinical trials. So Jenny, again, very appropriately highlighted the tremendous importance of clinical trials in myeloma, and I'm going to spend just 2 slides to talk about this. Clinical research really is critical, especially these days where there's so many things out there, so many new medications, so many new options for people. Clinical trials are really how these things get FDA approved and how they become broadly available. If new things are not tested in good clinical studies, they don't get approved. They could be the best thing in the world in a test tube in a lab, but if clinical studies aren't done that prove that these things work and they're safe, they will never reach patients. So clinical research is incredibly important because that is the pathway to get these new things improved. I'd point out that almost everything, if not everything, that we use to treat myeloma now in 2023 is only available because of people who have gone before you with this journey that participated in studies to get the current medications approved. And this includes things like CAR-T, bispecifics, Revlimid, all the other key medications that are out there. Another thing about clinical studies is that especially these days, there are a lot of options that are tremendously promising, highly effective, likely very safe, and they're only available through clinical studies because they're not yet FDA approved. And so clinical studies are a really nice way to get access to the newer and fancier stuff that's out there, which we hope is going to be better. And then again, participating in research, often when we do this as part of therapeutic studies, we treat somebody's myeloma, which allows us to, help the person who actually has the myeloma, but similarly or at the same time, we also get more information about the myeloma from that person, their response to therapy, side effects, which allows us to get smarter, and that allows us to help other people with myeloma. And then finally, a lot of this often comes up about, I don't want to be a guinea pig. And I'd point out that people who participate in studies are not guinea pigs. So research studies are designed not only so that you're sort of a person in a lab, getting a treatment and sort of like a guinea pig, but studies are really designed to be as ethically appropriate as possible, to be as safe as possible, so that they're really designed around a participant's safety just as much as they're designed around the fact that they're trying to generate good science and good data. So research is really designed around the safety of the people participating. And then I'd point out that even if we often talk about therapeutic studies, so looking at new medications, new approaches, that sort of thing, that's a lot of what the focus is with clinical studies in myeloma, but I'd point out that there are also observational studies, so it may not always be that the current trial looking at the latest drug option is the appropriate option for you, but there are many other studies that we can participate in which are observational, which basically allow us to learn from your experience with myeloma without changing anything about your therapy. So sometimes these are things like quality of life studies. We do a lot at UNC with geriatric assessment studies. Sometimes they're biomarker studies where we may collect a little bit of extra blood or bone marrow when you're having those tests drawn anyway. And these sorts of things allow us to get smarter about myeloma without making actual changes to your therapy. And so I would definitely encourage everyone to ask your doctor about clinical studies. And I think that's it.